Hello, everyone, and welcome to today's webinar, Congenital Cytomegalovirus, Updates on the Diagnostic Algorithm During the Neonatal Period and Beyond. I am Michelle Ashton of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin Molecular. To learn more, visit diasorin.com. Now let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want and any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now present today's speakers, Dr. Marianne Lerez-Ville and Tiziana Lazzarotto. For a complete biography on our speakers, please visit the Biography tab at the top of your screen. Marianne and Tiziana, you may now begin your presentations.
So CMV is the most frequent cause of congenital infection. The worldwide prevalence was 7 per 1,000 births in two meta-analyses of the literature, and the prevalence in Europe was 4 per 1,000 births in 6 screening studies. It's the most common non-genetic cause of hearing loss and a major contributor to permanent neurologic disability. The fetal infection may occur after 3 types of maternal infection, either a primary infection or a reinfection. Indeed, reinfections are possible because the immunity is incomplete, and second, there are a high genetic diversity among CMV strains, and a seropositive person can be reinfected with a new strain genetically distinct. And the present woman can be infected through a reactivation of an endogenous latent strain. Material viremia can lead to placental infection and then to fetal infection. The transmission rate to the fetus is 30 to 40% after a primary infection and is unknown after a reinfection or a reactivation, but is thought to be much lower, around 4 to 5%. So non-primary infection, meaning reactivation or reinfection, explains approximately 50% of congenital CMV infection in European countries. I've reported here in that slide the results of 2 screening studies in Europe. The first one was held in France by our group, and we screened nearly 12,000 neonates, knowing that the maternal seroprevalence in our population was 60%, and the rate of CMV infection at birth was 0.37%. 52% of the infected neonates were infected following a maternal primary infection, and 48% were infected following a maternal non-primary infection. The other study was held in Finland. They screened nearly 12,000 neonates. The maternal seroprevalence was 62% in the population, and the CMV infection rate at birth was 0.2%. 47% of these neonates were infected following a maternal primary infection, and 53% following a maternal non-primary infection. It is very important to understand that long-term sequelae are equally frequent after a maternal primary infection or a maternal non-primary infection. And you see here in that slide a table coming from meta-analysis of the literature that shows that hearing loss and neurodevelopmental disorder were equally frequent in babies infected after primary infection or after non-primary infection. Another important notion to understand is that after a maternal primary infection, almost all long-term sequelae are seen when maternal primary infection had occurred in the first trimester of pregnancy. And you see on that slide a table coming from a meta-analysis of the literature that shows, you can see that hearing loss and neurodevelopmental impairment in infected fetuses came in at a frequency of 23% after infection when the babies were infected after a maternal infection in the first trimester, and the long-term sequelae were close to zero when the babies were infected after a maternal infection in the second or in the third trimester. This link between gestational age and the risk of sequelae is unknown after maternal non-primary infection, but is thought to be the same, meaning only after a first trimester maternal infection. So universal neonatal screening is not recommended in any country. However, neonatal diagnosis is recommended when a maternal primary infection has been documented in the presence of compatible neonatal symptoms or in neonates failing universal hearing screening. Knowing that neonatal hearing screening will only detect 20 to 60% of congenital CMD-related hearing loss, indeed it misses the late onset cases. So neonatal diagnosis must be done within 3 weeks after birth. Indeed, if you do a PCR later and the PCR is positive, it can be congenital infection, of course, but it also can be early postnatal infection. So the method to use is PCR. Culture should not be considered anymore because it's less sensitive than PCR. The sample we can use for a neonatal diagnosis is urine or saliva, which are equally rich in viral DNA. Usually saliva is preferred because it's easier to collect, and the sensitivity is similar in both types of samples. However, the specificity is lower in saliva with positive predictive value around 50%, and this because the presence of low amounts of CMD DNA from breast milk or genital secretion may contaminate saliva at sampling. So a very important message here, a positive result in saliva should be checked in a second sample of saliva or urine. So this slide resumes how to do a neonatal saliva sampling. First, you have to collect saliva in between feedings, usually before the next feeding. You have to check for the absence of maternal milk in the neonate's mouth. If milk residues are visible, you have to eliminate them with a sterile compress. And this step is important to avoid contamination of the saliva sample with CMD DNA from maternal milk. Then you apply the swab in the internal side of the cheek for 20 to 30 seconds until the swab is soaked with saliva. And finally, you place the swab in the transplant medium and send it to the lab. Qualitative PCR can be used for diagnosis, but quantification in copies per ml or semi-quantification by CT value may bring further information. For example, it can discriminate between contaminated samples and true congenital infection. You see on that slide that in contaminated samples, the median viral load is extremely low, 2.2 log copy per ml, while in true congenital infection, the median viral load in saliva sample is very high, 7.6 log copy per ml. Here we tried to look for saliva viral loads at birth according to the trimester of maternal infection, and you can see that if the neonates have been infected after a maternal infection of the first or the second trimester, the viral load in saliva is very high, 7.5 and 7.6 log copy per ml, while if the mother had had her primary infection in the third trimester, the viral load in the saliva is much lower, 5.6 log per ml. And even you can see in green here that when the maternal primary infection happened after 54 weeks, the viral load in the saliva can be very low. So CMV DNA load in saliva at birth is high, over 5 log usually, except in cases with late third trimester maternal contamination or in cases with contamination of saliva by maternal CMV DNA. To do CMV diagnosis, neonatal CMV diagnosis, we can use the assay, Simplexia congenital CMV assay from Liaison Diacerin. This assay may be run on the Liaison NDX instrument. This instrument can run 8 samples per hour. It's quite easy to use, very compact, as you can see in the photo there. It's based on real-time PCR assay without prior extraction, and it's run for qualitative detection of CMV DNA in saliva swabs and urine collected in neonates less than 21 days old. The detection threshold is 500 copies per ml in saliva swab. You can see there the results of a positive and a negative test. The positive test you see 2 curves. The green one corresponding to the CMV target, and the purple one corresponding to the internal control target. And in the negative results, you only have, of course, 1 curve corresponding to the internal control. In our lab, we did a correlation study between the reference CMV real-time PCR from our lab and the Simplexia congenital CMV assay. We tested 50 saliva samples collected from 50 infants below 21 days of age and stored in UTM transport media. There were 30 positive samples from infected neonates and 20 negative samples from uninfected neonates. And you can see that the concordance between the reference lab methods and the Simplexia assay was perfect, 100%. We tried to correlate the Simplexia CT values and the log values obtained in positive samples, and you can see also that the correlation was quite good. Is it possible to use whole blood samples for congenital CMV neonatal diagnosis? The sensitivity of CMV PCR in neonatal blood is around 90% for diagnosis of all cases of congenital CMV. However, the sensitivity in the subgroup of neonates who will develop sequela is close to 100%. In this slide, I have reported the results of CMV DNA detection and quantification in all blood samples at birth in the French cohort of infected neonates. And you can see that 91% of all infected neonates had a positive CMV PCR in whole blood. But all children, 100% of children with sequelae had a positive CMV PCR in whole blood. And this is similar to the results obtained in the US cohort, where they found that all children with sequelae had a blood viral load at birth over 3.3 log. Now, which tests can be used for retrospective diagnosis of congenital CMV beyond the neonatal period? Can we detect CMV DNA in saliva? So, a positive detection after 3 weeks of age may be due to congenital CMV, but is mostly likely due to a postnatal infection. However, a negative detection in saliva in babies less than 6 months excludes the diagnosis of congenital CMV and is unlikely in babies aged between 6 and 12 months. And you can see that on this slide, where I reported the kinetics of saliva viral load between birth and 1 and 2 years of age in our French cohort. And you can see that CMV DNA in saliva was positive in 100% of congenitally infected children up to the age of 6 months. And at 1 year, 4% of congenitally infected children did not have detectable CMV DNA in the saliva, meaning that 96% had still CMV DNA detectable in the saliva. For retrospective diagnosis, we also can use CMV PCR and DBS on dry blood spot from Guthrie cards. We have to be aware that the analytical sensitivity is lower with PCR in DBS than with PCR in fresh whole blood. Because a small amount of blood is analyzed, 1 DBS is only 50 microliters of blood. And second, the DNA is difficult to extract from the card. So the detection threshold of CMV PCR in DBS is between 1,000 and 10,000 log copies per ml, depending on the technique used. And it's much lower, the sensitivity of CMV PCR in fresh whole blood with analytical sensitivity with, detection threshold between 200 and 500 copies per ml. Therefore, the clinical sensitivity of CMV PCR in dry blood spots is around 70 to 80% to detect all cases of congenital CMV and 90 to 95% to detect all cases with sequelae. On this slide, I've tried to resume the algorithm for the diagnosis of congenital CMV in infection in the neonatal period and beyond. If the baby is less than 3 weeks, what is recommended, of course, is the CMV PCR in saliva or urine. If the baby is aged between 3 weeks and 6 months, you can test the CMV PCR in saliva or in urine. And if it's negative, this excludes congenital CMV. If it's positive, you can't know if it's congenital or postnatal. So you have to do the CMV PCR and DBS from the Guthrie cards. If the baby is over 6 months, you can do a CMV serology. A negative IgG, of course, excludes congenital CMV. A positive one, it can be congenital or postnatal, and you can, again, try to do the CMV PCR on DBS if the Guthrie card is still available. And if the Guthrie card is not available, has been thrown away, you have to gather indirect evidences such as maternal seroconversion, growth retardation, compatible abnormalities, and cerebral MRI. So to finish, are we ready for congenital CMV universal neonatal screening? There are some pros, like it's a frequent condition. The universal neonatal screening would be able to pick up all infected neonates, those infected after maternal primary infection, but also those infected after maternal non-primary infection. While if you screen maternal serology, you will only pick up neonates infected after maternal primary infection. If you do the diagnosis, you can use the neonatal treatment by ganciclovir for 6 months, and this is for symptomatic neonates. And this treatment is significantly improves hearing and cognitive functions, although mildly. And of course, it's beneficial to have an early detection of hearing loss because it improves speech development. Against the neonatal screening are first the ongoing debate on the best method for this universal screening. Should it be saliva screening, which would obviously offer the best sensitivity, but it's rather difficult to organize? Or should it be screening on DBS, on dry blood spots, which would be easy to organize since DBS are routinely collected at birth? But we really need prospective studies to establish the sensitivity of PCR on DBS to be sure that it detects all cases with sequelae. Moreover, universal neonatal screening could raise parental anxiety and parental psychological discomfort, and this has to be evaluated. And of course, good cost-effectiveness study must be done before implementing the universal neonatal screening. So I have finished there, and I give, and now Tiziana will start her talk.
Perfect. We know that the congenital CMV infection is a very important public health. And in these slides, I would like to show, because it is a public health, more children may be affected by congenital CMV than by any other better-known childhood disorder, such as fetal alcohol syndrome, Down syndrome, spina bifida, and HIV and congenital rubella syndrome. So in 2015, there is a very important manuscript by Gail Daimler, the pediatrician in Houston, and she explained what is the very important public health for congenital CMV infection, because she identified CMV, the elephant in our living room, because it is a major public health problem that for decades has been under-recognized and unaddressed. So, for the pathogenesis, it's very important to know why the virus spreads via the blood and can be transmitted to the fetus, because in this case, the placenta represents an efficient barrier in many cases. That means that for mother-fetus transmission to occur, in addition to spreading via the blood, the virus must be able to cross the placenta barrier. Here, I reported now the natural history of CMV, human CMV fetal infection. The virus is present in the blood, in the maternal blood, and infects trophoblasts, fibroblasts, endothelial cells, and after the replication in the placenta, the virus comes into contact with the fetal blood, and at this point we have the fetal infection. And in congenital CMV infection, in the newborns, from 10 to 15% of newborns are symptomatic at the birth. And when we have symptoms at the birth, we can recognize low birth weight, fetal growth retardation, petechiae, jaundice, hepatosplenomegaly, purpura, sensory neural hearing loss, microcephaly, ocular defects, dental defects, pneumonia, and CNS sequelae. It is a very big, very important problem at the birth, because in this group we have 10% of newborns at the risk to have mortality. In fact, the mortality rate is about 10%. And furthermore, from 50 to 70% of the symptomatic newborn at birth, we have the risk to develop severe sequelae. In asymptomatic newborns, and we recognize a percentage between 85 and 90% at birth. However, 8 from 50% of them go on to develop severe sequelae. In particular, when we recognize the severe sequelae, every time we recognize sensory neural hearing loss and mental retardation. And in general, we have about 2 out of 1,000 newborns suffer from a congenital CMV infection. For the birth prevalence, in this moment, every time we say in countries with low population density, we can recognize a low risk of congenital CMV infection. The birth prevalence in these countries is from 0.5 to 0.7%. Whereas in countries with a high population density, the birth prevalence is higher, between 8 to 2%. And in this moment, it's very difficult to have a very clear data, because if you read the data in this table, I reported the literature data, very recent literature data. As you can see here, we have the percentages of the congenital CMV infection at birth are very, very variable. We recognize a significantly variable in both countries with low population density and in countries with high population density. This is the reason that today it is very difficult to identify a real risk. However, we can surely say that the overall birth prevalence in the world is of congenital infection is 0.64%. Despite this, the only 9% of women know about CMV before and during the pregnancy. And we can say that congenital CMV infection in this moment is a very important public health problem. So for the diagnosis, all consensus document, international, European, non-European documents recommend the diagnosis, neonatal diagnosis, in the case of documented or suspected maternal CMV infection during pregnancy, and in the case of suspected neonatal CMV disease, and in the case of newborns who fail hearing loss. And I would like now to show our results from a long monitoring, and we identified in 1,170 pregnant women with primary infection and non-primary infection over a span of 14 years. And in the group of non-primary maternal infection, we identified 205 women, and in this group we identified seven transmission equal to 3.4%, and in this group we identified about 40% of newborns or fetuses with symptoms. Whereas in primary maternal infection, we found 965 primary maternal infection, and the percentage of transmission is 23%, and in this group we found 18% fetuses and newborns with symptoms. So this important collection of results is an important collection because it is in agreement with all literature data and confirm the very important problem for the transmission and for the risk to have fetuses or newborns with symptoms after primary and non-primary infection. So when we analyzed the data from newborns infected, CMV infected newborns, in particular over a span of 18 years, we found 63 infected CMV newborns, as you can see here, and 10 newborns from non-primary infection equal to 15%, and whereas 48 infected newborn come from primary maternal infection equal to 70%. And finally, we found a very small group with congenital CMV infection. 5 newborns come from undefined maternal infection. In this group, we recognized the maternal infection, but we were not able to identify if a primary or non-primary infection. So, as you can see here, when we analyzed the risk to have symptoms at the birth, and we found a very high percentages newborns with symptoms at birth from mother with a non-primary maternal infection during pregnancy, and we found a group with symptoms in newborns from primary maternal infection. But in this case, the percentage is lower than the first. So, what about now for the screening? I confirm the opinion, and Marianne explained which are the reasons. In this moment, universal neonatal screening is not recommended, okay? But in United States, there is a very important experience. In particular, The National CMV Foundation is a non-profit organization has partly determined the introduction and passage of a legislation in order to combat the congenital CMV infection by CMV education and or infant CMV screening. The situation at April in 2019 in 10 states, blue color dark, screening or education have been law enacted. In 5 states, blue color light, proposed the introduction, the screening or education in order to combat congenital CMV infection. And finally, in other 15 states with gray color in the map is under discussion. This is an extremely important position, and probably it is an important experience for not only the United States, but for all countries in the world. We know that the gold standard for the diagnosis and for the screening is the urine and saliva real-time PCR. It is very important to have the examination during the first 3 weeks of life. This is a very important point because after that time it may represent an infection acquired at birth or during the neonatal period. For the screening, which is the opinion of the international community, I think this is we are very agree with the manuscript published by Gail Daimler in 2020 in Clinical Infectious Diseases, newborn screening for congenital CMV infection, it is time. And in the last years, probably so many manuscripts publish different experience and different approach for CMV congenital screening. And probably this is the reason that it is the time to introduce this screening in each country and introduce the possibility to test all newborn at birth. So, which is the real reason? CMV is okay. CMV is the major cause of childhood disability, but frequently goes undiagnosed. It is very important to have early diagnosis because it's possible to offer antiviral therapy for selected infants. And it is very important to have early diagnosis, early screening for early intervention for hearing loss. And we are agree that the saliva is a preferred sample type for CMV screening in newborns. And the results that we obtained from Alabama group from Suresh Boppana in 2011, the data, the published data were very important because the group recognized this very high sensitivity, 100%, and very high specificity for the saliva sample used to screen for congenital infection. However, when we test the real-time PCR saliva sample and obtain a positive result, it is also mandatory to test urine sample due to the high level of possible contamination with the breast milk. Now, I would like to show some data that we obtained, some results that we obtained with our experience. with this new real-time PCR. The name is Simplexa. It is very similar to data just presented by Marianne. So I think this is an important experience because this qualitative detection of CMV DNA is important because we can use unprocessed saliva, swab, and urine samples. So we are able to process the samples without preliminary extraction. And the system is associated with 8 reusable wells for direct amplification of targets in about 1 hour, from 1 to 8 samples per time. And then a very important point is the possibility to have internal control in order to validate the negative results. Our study analyzed 60 set of samples archived and 30 sample saliva collected with UTM swabs and 30 urine samples from neonatal newborns before 21 days old. And in the first table, I show you the positive results in saliva and urine. And we evaluated the results obtained during the routine with our reference method. Positive results in all samples, urine and saliva, and we obtain the same results with the Simplexa congenital CMV liaison MDX. And the agreement was 100% in both fluid biological samples. So, same results we obtain with negative results. Saliva and urine, 15 samples. Also in this case, we compare the reference method with the Simplexa method, and the agreement we obtain 100% of agreement. And another important point is when we analyze the average threshold times, the CT, for positive saliva and urine, and the CT for all samples were between 24 and 25 in all positive samples, and in all negative samples the amplification of the internal control were with an average of CT of 29. So it is an important part because the system is easy and it is rapid that can aid in the quick and correct diagnosis of congenital CMV infection. And it is possible to test in the same run both saliva and urine samples. So I would conclude my presentation with results that we obtain after a prospective multicenter clinical trial. And we presented the schedule of our prospective multicenter trial during the last International Congenital CMV Conference. Was held in United States in Birmingham in April 2019. And this is the first time that I show the data now because we concluded the study just at the end of August and of this year. And the title of this prospective multicenter clinical trial is identification of CMV DNA cutoff value in saliva sample for the diagnosis of congenital CMV infection. It is a multicenter clinical trial, and there are 3 centers. The first center here in Bologna, in my hospital. The second center is a hospital very close to Milan, and the last hospital is in South Italy, Bari. And we have 2 aims. The first, if a viral DNA cutoff value in saliva can discriminate a congenital infected newborn from a non-congenital infected one. The second is if a subsequent saliva sample is indicated a confirmatory testing for congenital CMV infection diagnosis, or it is mandatory to test a neonatal urine sample. So this is our results, and we found 54 saliva sample, and in this group we obtain in the first swab a false positive results. In particular, the percentage is higher, is 1.7%. So as you can see here in the table, in 50 samples, we obtain false positive results only in the first saliva swab, and we obtain in the second saliva swab negative results, the same in urine samples. However, in 4 samples, we obtain positive results, false positive results in the first swab. However, we obtain again positive, false positive results in the second saliva swab, and in the urine we obtain a negative results. So in this case, in our experience, and out of 54 samples with false positive results in the first swab, we obtain 4 saliva specimens and 4 second saliva swab with false positive results. And in this group, we enrolled 3,151 newborns, and we recognize 21 newborns with congenital CMV infections, and the birth prevalence was 0.66%, and it is in agreement with the literature data. And in this group, we obtain positive results in the first, in the second swabs, and in all urine samples. And disagree with Mariana data because we found in all cases very high viral load. So this is reported in these slides, the viral load that we obtain in saliva swab and the urine swabs, in the urine samples in the 21 samples from newborns with congenital CMV infection. Finally, I would like to show which is the results in relation to have the symptoms at birth, and we recognize 10 newborns, 10 newborns with congenital infection from primary maternal infections, and 2 newborns, in particular 2 newborns have severe symptoms, and both receive therapy, valganciclovir therapy for 6 months. So we had 7 newborns come from non-primary maternal infections, and 3 newborns from unknown maternal infection. So in this case, the mother did not receive any test before or during the pregnancy. And finally, 1 newborn from undetermined maternal CMV infection. During the monitoring after the delivery, we identify a baby with severe monolateral deafness, and we identified this symptom at 5 months after the birth. So, in conclusion, I would like to report here and in the next slide the principal takeaways of the diagnosis and the screening of congenital CMV infection. I think it is important to follow the recommendation for the diagnosis and for the screening, in particular for the material that we analyzed. And it is very important to take a caution approach when interpreting the positive CMV screening results by testing a subsequent saliva sample. In this moment, probably it's better to use every time the urine as confirmation material for congenital screening or diagnosis for CMV infection. And finally, it is very important to underline that an infant with congenital CMV infection must undergo clinical laboratory and instrumental assessments within the first month of life. This is an important point because it is very important to identify newborns very early after the delivery. Thank you, and thank you for your attention.
Thank you, Marianne and Tiziana, for your informative presentation. We will now start the Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask Question box located on the far left of your screen. We'll answer as many questions as we have time for. All right, let's go ahead and get started. Okay, so our first question is for you, Tiziana. While universal screening is not recommended by any European Union authorities, could the targeted screening approach be reliable and applicable in terms of cost-effectiveness strategies?
Yes, it is very important but so hard question, because in this moment we agree that it is the time to have a neonatal screening, but in this moment we don't have a very important experience in terms of cost-effectiveness strategy. So I remember some publication from Germany, from other European countries, but it is very difficult to explain with numbers the problem when we don't have the possibility to identify very early the CMV infected newborn. So I think this is important to follow the American experience in this moment because it is only from this important American experience we have the possibility to understand very well which is the real approach to in order to identify very early the infected CMV newborn.
Thank you so much. Since DVS as a matrix for congenital CMV infection detection shows low sensitivity, do you have experience in the use of amniotic fluid? If yes, is there a correlation in detection between amniotic fluid and saliva samples?
Yes, there is a correlation in detection between amniotic fluids and saliva samples. And when CMV PCR is positive in amniotic fluid, CMV PCR is always positive in the saliva sample at birth. But when the CMV PCR is negative in amniotic fluid during pregnancy, in 95% of cases, the CMV PCR is negative in the saliva at birth. And but in 5%, the PCR is positive in saliva, even if the PCR was negative in amniotic fluid. These cases are rare and they are explained by a late passage of the virus after the time that the amniocentesis was done to retrieve the amniotic fluid. And they have very good prognosis. These cases have very good prognosis.
Great, thank you so much. And now your next question is for Tiziana. As you mentioned and as reported in the scientific literature, urine is the matrix of choice to confirm a positive saliva sample for congenital CMV infection. Are there differences in CMV detected between two matrices for positive samples?
Yes, my answer is come from my data, my last results, because in our experience, in a few cases, only 4 cases in a very small group, but we obtain a positive results with the viral load is very low. But we obtain in the second collection of saliva a positive results. This is the reason that probably the urine is the matrix of choice to confirm the congenital CMV infection. And because if you use a qualitative PCR, and if you do not check the CT, and you don't have the possibility to recognize the viral load, it's possible to have a positive results in the second collection, and you recognize a false congenital CMV infection. So in this moment, probably it is better to have cautions to consider the second saliva swab as a sample, control sample.
Thank you so much. It looks like it's time for one more question, and this one's for you, Marianne. Why is the threshold of 3 weeks for the correct sample collection for congenital CMV detection important?
Yes, indeed, CMV diagnosis must be done within the first 3 weeks of age. And because if the CMV PCR in saliva is positive after 3 weeks of age, you cannot tell if it is a congenital infection or a postnatal one. So postnatal infection can be very early because the baby can be infected through birth, through the passage in the birth canal, and it can be infected with maternal milk, as we said. So it's important because we know that only congenital infection can lead to long-term sequelae, and postnatal infections are mild and they do not lead to long-term sequelae. So it's important to have a differential diagnosis between congenital and postnatal infection.
Thank you again, Marianne and Tiziana, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, DSR Molecular, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their questions. As a reminder, any questions we did not have time for today and those submitted during the on-demand period will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's event. Until next time, take care. Goodbye.